But you have a question already that regards biomarkers. Could you read the question, please, and then?
Sure.
Yeah.
So which biomarkers do you think are showing the most promise for tracking resistance to new wave immunotherapies? Yeah, this is a great question. I'm going to ask Dr. Lonio what he thinks too, but honestly right now, if I knew at least what antigen these patients were, what antigens that they still expressed, but at the level of mutations, right? That's the biggest thing, is that unfortunately BCMA expression doesn't mean this patient's going to respond to BCMA therapy again, because of these mutations we're seeing. So if we had a way in clinic to easily check that when I did a bone marrow and I can get it in 1 to 2 weeks, I think that would help me the most to say, okay, this therapy could still work here. But I think it's really, really hard. And then I think for T-cell health, we don't have great ways to see if patients have better T-cells. So for instance, maybe giving bispecifics early, but if you can wait a year or longer and give something else that can help their T-cells, maybe then I can make a CAR T. But right now, I'm getting a lot of manufacturing issues or failures if I try to go right after, a bispecific when it's in the 4th, 5th line that these patients are getting it. So again, maybe it'll change when we go earlier, but I do think with our therapies, our sequencing are really going to affect our T cells. So we need to know what helps T cells and can give us that improved T cell health versus not. And if there's a test that told us what those T cells are, like some of your studies have shown, and I can do that quickly in the clinic, that would be fantastic.
Yeah, I think the only other thing I might add would be the idea that a single target is going to eliminate myeloma is probably not realistic. I mean, the reason we got where we are today in the field is combination therapy. So rather than waiting for mutations to develop or waiting for downregulation or loss of the receptor, I think hitting the myeloma cell with multiple different immune targets over a short period of time is ultimately how we're going to get those better outcomes that you're talking about. And there's no biomarker for that. It's really just using the principles that DeVita and others came up with 50 years ago and applying them to immune therapy.
I have a question regarding this topic for the two of you. What about p53 mutations? Do they impact on the CAR T and bispecific outcome? Are there data already for the myelomas?
Yeah, so unfortunately, even though this is an antigen on top, right, people think, oh, it shouldn't affect it, but it does. So just like EMD, they still do well compared to other therapies we have out there. But in forest plots and things like that, you'll always see 17p or high-risk patients or ultra-high-risk patients still don't do as well. So this is where these combinations or even maintenance, afterwards are probably needed for better outcomes for that group of patients.
Unfortunately, it's the same for the lymphomas.
Yeah, and I think this is where duration of therapy is probably more important. So we know that with a standard risk patient, if you achieve MRD negativity that's sustained, you can do well for a really long time. In the high risk, that's not always the case. And so even our current methods of detection, 10 to the minus 6, may not be sufficient to really understand what a 17p patient means.
Okay, there's one more question for Krina, which is what are the key considerations when selecting between BCMA, GPRC5D, or FcRH5 targeted therapies?
Yeah, it's a good problem to have, except I think it's access, so whatever I can get. And I think we are finally at a point where BCMA therapies, bispecifics and CAR Ts are much easier to finally get for my patients when they come in. I don't have to worry as much about finding another therapy to get them through until I can get that apheresis slot in 3, 4 months, 6 months, or I have a bispecific I can use. I think the other two, GPRC5D we also have. And again, it comes down to side effects and tolerability, and what do I need right then. And so for right now, I will say based on FDA-approved drugs, I will use BCMA therapies first. We have more data. I know how to manage those side effects, especially if it's a one and done. And I'm using talquetamab, for instance, post-BCMA therapies. But once we have FcRH5, then we'll have to really see what we use.
Yeah, no, I would agree. Sometimes I joke and say alphabetical. That's how we choose. And that's where we have the most data, to be honest. So, but I think it's what do you have access to, and which side effects do you feel most comfortable managing?
Well, thank you. I think this is a good end to our discussion.